Most clinicians spend a lot of time learning stemmer and atrial fibrillation, but some of the most important ECG diagnoses are the ones associated with sudden cardiac death. And today we are going to go through 5 conditions every healthcare professional should recognize. 1 is Brugada Syndrome, 2 is cardiolaminogenic polymorphic ventricular tachycardia. Another is hypertrophic cardiomyopathy. We have familial dilated cardiomyopathy. So let's start with Brugada. We've discussed this extensively. There are 5 clues you should know with your Brugada, and 1 is your V1 to V2. Second is there pseudo right bundle branch block? Is there ST elevation that is coved or versus saddleback shape? What is the T wave pattern looking like? Is it T wave inversion, which occurs in your type 1, or in type 2 you have your biphasic T waves or your upright looking T waves? But we know that Brugada is important because it can cause sudden cardiac death during sleep. It has a strong age and gender correlation. You have middle-aged Asian men having a high prevalence of this condition, and it can be inherited in the autosomal dominant pattern. Now, in terms of CPVT, catecholaminergic polymorphic ventricular tachycardia, is one of the commonest forms of juvenile sudden cardiac death. And the thing about this is that it can be triggered by emotion and effort, just like your long QT syndrome. And what you have, I try to draw a quick sketch here, but what you have many times is your bidirectional and polymorphic ventricular tachycardia. So if you look at the direction of your QRS complexes, it is swinging both ways. And you can have normal resting ECG, a normal echocardiography, but if you do exercise stress testing, you'll be able to reproduce this ECG. It is very important because many of these patients will say that their symptoms are resolved when they are in the hospital, but when they are stressed up, they will come up with this ECG. Now, in familial dilated cardiomyopathy, what you have here is that this can be inherited. The key points that you need to know is that around 30% of idiopathic dilated cardiomyopathy is familial, and the ECG is often abnormal. The ECG clues you can have here is you can have lateral lead abnormalities. So we often say that T-wave inversion are often markers of cardiomyopathy. T-wave inversions are always abnormal in your inferior leads and your lateral leads. Sometimes they can be normal in your anterior leads, not all the time, but it's a good rule of thumb that when you find T-wave inversion in your 2, 3, AVF, 1, and AVL, it is abnormal. You could also have ST segment depression that is greater than 0.5 millimeter depression in 2 or more contiguous leads. So if you're worrying about sudden cardiac death, remember familial dilated cardiomyopathy, right? And especially if it is in the family. Now with ARVC, that's arrhythmogenic ventricular cardiomyopathy, the age range is between 20 to 50 people between 20 to 50 years of age, right? It is one of the most common causes of sudden cardiac death in athletes. Now, what is ARVC? You have fibrofatty replacement of the myocardium, and about at least 10 different genes have been implicated in ARVC. A common pathognomonic feature is epsilon wave, although it is very specific. Sensitivity is just about 30%. So people with ARVC can totally present with a normal ECG. And the epsilon wave is this slight flaw you have at the end of your S wave. You can also have epsilon waves in other conditions. It is worthwhile to know that. But what you have apart from your epsilon wave that can tell you about ARVC is that there is T-wave inversion. There is often a complete or incomplete right bundle branch block. Now, with your HOCM, you will have deep and narrow Q waves. Now, your Q waves are pathological when they form more than a quarter of the QRS complex. And so deep and narrow Q waves in inferior and lateral leads. You can also have your signs of LVH, left ventricular hypertrophy, if you remember your Sokolow-Lyon criteria, in which you have your R in V1 and S in V6 being more than 35 millimeter. They could be your signs of LVH. And remember that the apical variant often presents with T-wave inversions. I hope this has been useful to you. Below, I'll be linking 1 or 2 resources that I think that you can also benefit from in learning more about causes of sudden cardiac death.